Congratulations.
Okay, good morning, everyone. This is very weird being back at this podium for the first time in about 3 years, but it is great to look out and see everyone. So thank you for being here today, either in person, and thank you for being here online. It's a special Grand Rounds where we get to recognize the accomplishment of one of our faculty members, and we'll talk more about that shortly. Just a few reminders for things that are coming up and announcements. First, I want to congratulate Dr. Borman Shope, the entire education team, for a very successful match day this past Friday. Wow, clapping in person. This is good. So very successful match day. Ramadan begins this evening at sunset. Please wish your Muslim colleagues a blessed Ramadan. We have the press conference coming up a week from Friday. A good chance for our fellows and students to display their research work. And then May 23rd will be a story slam, and there'll be more information about that along the way. Okay. So I wanted to start today with essentially a sad announcement, but I think it's important to take a minute and remember Dr. Ed Kaplan. As many of you know, Ed was a member of this department for over 50 years. Ed was a cardiologist, he was a infectious disease specialist, and he was a person that was incredibly devoted to this department and to his patients. Ed actually ran an outreach clinic in Pine Ridge, South Dakota for probably decades, serving that population. Ed passed away this past Saturday night, and I just want to acknowledge Ed's passing. Okay, so this is a wonderful day. If I was the dean, I'd say this is a glorious day. He's probably heard that, and I'm going to hear about it later on. But this is really a great day for the department to have the opportunity to pass on the gold-headed cane to Dr. Dana Johnson. So the gold-headed cane is recognized as a symbol of excellence. This is a tradition in this department that goes back over 40 years to Dr. John Anderson. And the story of the gold-headed cane goes that it was first owned by a Dr. John Radcliffe, a prominent physician in Britain who apparently attended to King William III during his bout with smallpox. This is carried forward and has been recognized as a symbol of excellence and preeminence among physicians. The Department of Pediatrics awarded this honor to the physician's physician beginning in 1972, and we've had innumerable awardees since that time, some who are here with us, some who are not, but it's really a testament to the excellence with which people do their work. The 2023 Gold-Headed Cane Award goes to Dr. Dana Johnson. I think most of us believe we know Dana. I thought I knew Dana. I know a lot more about Dana now than I did a few days ago when I started pulling this together. And it's even more impressive than I might have thought. So Dana is a graduate of North Park College in Chicago, Illinois. He came to the University of Minnesota following college, received his MD degree in 1975. He also received a PhD in anatomy at the University of Minnesota. And you don't see too many PhDs in anatomy. His PhD thesis was a streptozotocin and nicotinamide-induced rat islet adenoma, characterization of in vitro proinsulin and insulin synthesis in whole tumor tissue and tumor-derived cell-free systems. It's quite a thesis. It was remarkable to see him carry this work forward really for about the first 10 years of his faculty time. So following all this, Dana started his internship, did his residency, moved quickly into fellowship. essentially joined the faculty here in 1980 as an assistant professor. He was promoted to associate professor in 1984 and then to full professor in 1992. As I mentioned, Dana's career really started off as a basic science career. His research built on the biology of fetal and neonatal pulmonary neuroendocrine system. This was a good fusion of his interests in neonatology and his PhD work. And he continued to publish this work in strong journals, a 1982 paper in Pediatric Research, another paper in Metabolism in 1984, contributing to our basic understanding of biology and that intersection between that and his work as a neonatologist. Probably towards the middle part of the 1980s, Dana added substantial clinical research to his portfolio. And some of these things that we take for granted, like steroids in premature infants and steroids to mature the lungs, weren't always a given. A couple of papers that I saw in looking through Dana's CV, and a paper in Pediatrics in 1981 talking about the effect of antenatal betamethasone. Again, this is now just accepted as fact, but somebody had to do the work of getting it there. A controlled trial of dexamethasone therapy in infants with BPD, published in The Lancet in 1983. And then Dana was not afraid to step out into the social challenges of those times. A paper in JAMA on life, death, and the dollar sign, medical ethics and cost containment. I actually think it would probably be good to go back and read some of those papers again. We seem to grapple with the same things years after year. Dana came into the field of international adoption in the 80s as well. And one of the things that has been most remarkable in his career is in the international adoption program. In 1986, Dana and his colleagues established the first multidisciplinary academic program in the world devoted to the medical and developmental health of adoptees. In 1991, Dana, along with two others, Dr. Peggy Hostetter and another colleague, actually wrote the first paper on prospective medical evaluation of internationally adopted children. This was published in the New England Journal of Medicine in 1991. In 1993, Dana really had moved this research forward to look at the care of institutionalized children, not just in Europe, but really around the world, with major collaborations really basically on almost all the continents. He had a strong research program that was developing in China. He had work that was going in Eastern Europe and really was bringing that work home with him to the United States. This is what Dana recognized that was going on, essentially warehousing of children. And what Dr. Johnson did was he actually studied the impacts of that warehousing effect, that psychosocial isolation that these children were experiencing so early in life, at a time before we were talking about ACEs and things like that. Dana recognized this and even recognized the biology of this and did work to show how this psychosocial deprivation actually changed the biology of these children. This is just a picture from Romania, 1990, 1991. This was a series of slides celebrating the 30 years of adoption medicine of the program here. Dana moved this thing forward really to create an international adoption clinic. And that international adoption clinic has grown under his leadership and now the leadership of Dr. Judy Eckerly, and has completed over 30,000 pre-adoption reviews for people all across the United States who are adopting children. Dr. Johnson did more than just write it down and leave it in the public sphere. He actually did advocacy, and he took his findings and moved them forward through several ways. Dana has given literally hundreds of talks around the United States and around the world, multiple invited professorships, teaching others about this hugely important work. He's moved it forward by serving on multiple boards, and these are just a few of them, but the board of directors of the National Council of Adoption, and which he's on from 2015 to now, the Way Forward Project, senior advisor for Maestral International, and you're going to hear more about Maestral shortly, board of directors of the Spoon Foundation, Firefly Children's Network, and many more. He's also presented this work and these concerns to the legislators, both here in Minnesota as well as federally. Dana's received a significant amount of recognition for this, and I think it's nice to see what others are seeing. He received the Lifetime Achievement Award for Advocacy on behalf of vulnerable children from the American Academy of Pediatrics in 2019. He received the Lifetime Achievement Award from the Rudd Adoption Research Program at the University of Massachusetts Amherst in 2018. A Lifetime Achievement Award from the Joint Council for International Children's Services in 2012. And I can keep reading, but you get the idea. This man is truly a star and a father of the field of adoption medicine. Dana did something. Dana, we had to have one picture. I told Dana yesterday we weren't going to do this, but then this picture showed up in my email last night and we had to use it. That is Dana, and it really still looks like Dana. You've aged very well, actually. Dana's done something that's equally important, that we all need to consider when we have a body of work we want it to continue on. And the International Adoption Clinic has had to develop, had to change with times. International adoptions have slowed, and the new focus is on foster care. But the other thing Dana has done that has been excellent is he has recruited outstanding people to work with him. And this is just that group: Judy Eckerly, Kamara Gustafson, Maria Krapina, just all, and their staff, all essentially wonderful individuals who are going to carry this program forward. So with that, I'm going to turn this over to well, actually, the first thing we're going to do is go get the cane and give it to Dana, and then turn this over to Dr. Johnson. So Dana. I can stay over here. People online can see it. So Dana, on behalf of the Department of Pediatrics, congratulations.
Well, thank you very much. Couple of things about the cane. I'm very happy that it has a rubber tip, because it looks like I'm getting closer and closer to having to actually use it on a more regular basis. The other thing is that when I told Philip, who's going to speak, that I received the gold-headed cane, he wrote back and he said, the whole cane should be gold. And I said, well, that's only in the Department of Surgery. But truly, I can't even begin to tell you what this means to me. Simply saying thank you would just be a total understatement for what I'm feeling right now. When I think of who the past recipients were and think about people in the community in this department who are as equally deserving, if not more so, of this award, I'm truly humbled. Joe mentioned that I had received a number of Lifetime Achievement Awards, but this is very, very different because you actually know me. You know my faults as well as my strengths, and you still decided to give it to me. And I thank you for that tremendously. Um, I owe a lot to the department for being able to develop my career here. No one ever said no to me. No one ever asked why. When I asked for things, people said, "How can I help?" And it's been that way throughout my career. The collaboration in this department has been extraordinary. And I was looking through the number of divisions that we have now, and I think I've published papers with at least members of half the divisions throughout my career. Everyone's always willing to do that. And in terms of the developing the clinic, I have to say that there are so many people who have offered help for us. When we receive a medical review, there's often information in there that we don't have a lot of expertise in. And all of us who do reviews have reached out to people in the department over and over and received a great deal of advice. And that advice has not only helped us, but that advice has actually helped children reach many, many families that they wouldn't have reached beforehand. You've helped people make that leap of faith that's necessary to adopt a child with a medical problem. Two groups in the department I want to single out. One is the Adoption Medicine Clinic. Those who have worked with me since the beginning and helped found the clinic, and those who have nurtured it and improved it and maintained our reputation in the world of adoption. Thank you so much for all the support that you've given and all the time that you've spent. And thank you for the tens of thousands of kids who are now in families who would not have been otherwise. And then for my colleagues in neonatology, much of the clinic grew during the time when I was division head, and that split my time, and I couldn't devote it all to you. You were very patient and you were very supportive, and I thank you for that. And you continue to value me, and I hope to spend many, many more years with you doing what I love to do, which is taking care of babies. Then I want to thank my family. The price of academic medicine is time away from my family. And I thank you for your support and your never-ending love to me during that period of time and to the present. Thank you so much. And thank you for being here and for being online. When I was born, I lived with my grandparents, my parents, and my Aunt Nancy. So I was the first grandchild, and I was lavishly nurtured by those 5 individuals. I literally had 3 mothers and 2 fathers. And that helped me in ways that I did not appreciate until I started going into orphanages and seeing the blank looks on children's faces, the fact that they are profoundly deprived and were behind in terms of all of their developmental milestones. And we saw that in orphanages around the world where children didn't have the opportunity to be in parental care. You know, as a pediatrician, I knew parents were important, but my epiphany was that I didn't know how critical they were to the outcome of children. You know, the family really is the vessel in which our essence is distilled and we become fully human. I would say to my parents and my grandparents if they were here today, and I'll say to my Aunt Nancy, who's watching from her home in Massachusetts at the age of 92, that through simply loving me, conditionally and completely, that's responsible for any good that I've done in the world today. Now, I haven't mentioned many people by name other than Nancy, but I'm going to finalize my talk here by mentioning one person, and that's my son, Gabriel James Sunil Sai Johnson. Gabriel joined our family almost 38 years ago from India. He was the inspiration for the clinic. Gabriel, without you, none of this would have happened. So this award is just as much yours as it is mine. Thank you all again for coming, and thank you so much for the award.
I invite Raghu Rao, who will introduce our speaker.
Congratulations, Dana, again. You made all of us in our division and department very proud. And thank you for all your service to the children from all over the world. So it's my distinct honor to introduce today's grand round speaker, Mr. Philip Goldman. Mr. Goldman, he said I can call him Philip, is the founder and president of Maestral International. This is a team of global experts supporting the development, strengthening, and coordination of child protection and social welfare systems to meet the needs of children in diversity. Since its establishment in 2008, Maestral has worked in almost 100 countries in close collaboration with the UNICEF, USAID or USAID, the World Bank, and countless NGOs and funders. Prior to founding Maestral, Philip was a member of the World Bank Human Development Unit, and his regional focus was Central Asia and Europe, where he managed the preparation, negotiation, and implementation of bank operations focused on social protection, health, and education system strengthening. A graduate of University of Washington, UC Berkeley, and Harvard, Philip is an adjunct faculty in our division since 2018. In 2017, Philip and Maestral led a consortium that was one of the 4 finalists in the first MacArthur Foundation's 100 and Change Challenge competition for a $100 million award for a single proposal that promised real and measurable progress in solving a critical problem of our time. His success in becoming one of the 4 finalists highlights his ability to identify an important issue, in this case, childhood institutionalization, develop a strategy to change public dialogue on the issue, engage policy and change makers in multiple countries, and build consensus and extensive public support for the project through social media. Even though his consortium was not chosen to receive the $100 million award, they were awarded $15 million by the MacArthur Foundation to continue to build momentum on this important issue. Since 2018, Philip has been a member of the Lancet Consortium, Lancet Commission on the institutionalization and deinstitutionalization of children, and is currently a member of the Global Reference Group for Children affected by COVID-19. He has published several papers on this topic in Lancet and other journals. And at today's grand round, he is going to talk about global COVID-associated parental and caregiver loss and data overview and policy implication. Please join me in welcoming Philip.
Thank you, Raghu. And Dana, physician's physician. That phrase just captures you perfectly. And how like you to talk about your faults first before anything else. It just is a measure of your humility. The humility that I think we all appreciate, but in many respects isn't deserved in your case. 30,000 pre-adoption reviews from that clinic that you founded. 2 of those reviews were my children. My son in 1996 and my daughter in 1999, one from Ukraine and the other from Russia. Both graduated from university, starting out with great adversity in these warehouse environments. The support, the reassurance, the advice that your clinic provided at the time made an immeasurable difference in that foundation that they needed for a successful future. So we are beyond grateful. There's no words really for what you've done. And then in the intervening years, I was at the World Bank when we adopted our children. And then I moved on to this child protection mission that was just described. But we've had a lot of adventures together in Nepal and Vietnam and Russia. We've collaborated on a number of projects, and I've continued, of course, to maintain some links to the good work of the clinic and how that's expanded. So I just would say another round of applause for this amazing, amazing individual and physician's physician. Thank you. So let's see, do I just click? Yeah. I imagine many of you have seen the movie The Perfect Storm. It was a real event in 1991. It was basically a collision of three storm fronts. One actually originated here in the Great Lakes region and moved east, and another one came down from Canada to the south, and the third was Hurricane Grace, which came from the south, I'm sorry, the other came from the north. The three converged and the waves were 100 feet high. Why am I mentioning this? It's a metaphor for how we working in child protection globally see the situation of children today. And I just wanted to give a backdrop against it. We're going to be talking about COVID-19, but it's really a set of issues that are much bigger. It's the three C's, the three fronts creating this perfect storm for children of COVID-19, which we'll be discussing today, but also conflict in the Middle East, North Africa, and of course, Ukraine, and climate change, which is leading to very large increases in poverty and displacement around the world. UNICEF recently announced that this is the worst time for children that it's seen since its founding after the Second World War. And the international system has been quite strained in responding to this. Of course, with our news headlines here in the States, this isn't terribly visible today, but for those of us working globally, it's quite visible and quite concerning. And before we get into the issue of children losing parents and caregivers, I did want to highlight the specific impacts of the COVID-19 pandemic on children globally, and then we'll zoom in on the question of loss of care and parent. When we look at mortality, only 0.4% of COVID-associated mortality around the world has been children. Obviously, it's really affected older populations. But there have been what has been termed secondary impacts from the pandemic due to quarantine and economic disruption, loss of education, and so forth. And an estimated 1 billion children ended up in some sort of confinement. Overnight, about 143 to 163 million estimated range became thrust into severe poverty. That's defined by the World Bank as earning less than $1.90 a day. That's a subsistence minimum, just enough to maintain the calories you need to survive. So that was a shock. A big increase in lapsed immunizations, about 25 million children not receiving the immunizations that they need. Typically, something over 100 million a year receive immunizations, so that was a huge figure. In fact, the vaccine coverage dropped from about 86% to 81% from 2019 to 2021. First reversal in decades that we've seen on that. We're going to be seeing how all of this is going to be impacting some of the big issues that we were making such good progress on. Maternal mortality, infant mortality, stunting, and so many other measures that have a bearing on children's health and well-being. Just also to note, about 1 billion children a year are subjected to some form of severe violence a year. It's a shocking number. That's a pre-pandemic figure. When children were in confinement, the reports of violence against children just skyrocketed. Child helplines were receiving 300% increases in calls, a lot of anecdotal reports, massive increases in child marriage and teen pregnancy, and we could go on. So it was a very, very challenging time for children. We're still looking at this question of long COVID. I'm not a physician. I know there's a lot of research ongoing that's affecting about 4% of the world's children, according to UNICEF. Not a small number, and we'll just have to see as time goes on what that means for them. Whoops. Well, that's not a terribly critical slide. Our research on the specific issue of how many children lost a parent or a caregiver to COVID-19 was undertaken in collaboration with 16 experts from 12 agencies led by the Centers for Disease Control here, but also including WHO, the World Bank, USAID, a number of universities and the like, and of course, our organization. We'll be looking today at the numbers that we came up with from a variety of different perspectives. I'm going to hone in on some of the data for the United States specifically and for Minnesota. so we can make it a bit more relevant to us today. And then we'll talk about some of the implications and policy recommendations. The first study that we did was in the Lancet, and that was published in July of 2021. There we go. And then we were subsequently invited, actually a number of our team members, I wasn't part of this specific study, but by Pediatrics to, I'm clicking, maybe if I roll it, there we go, I'll try that, to look at the United States figures. That was published subsequently in 2021. The numbers were going up so quickly that the Lancet invited us to publish an update on the figures in February of 2022. And then there was a subsequent work in JAMA Pediatrics. And we have an ongoing widget online with real-time tracking of the data by country, region, and global data that Imperial College has been maintaining just to keep this data available and relevant. So you might have seen actually some of this. It got a fair amount of coverage in mainstream media and print publications as this all came out. I won't go into too much detail on the methodology. I'm happy to discuss it with any of you afterwards. Suffice it to say, it was extremely challenging to come up with these figures. Many countries around the world don't really do a great job of publishing mortality-related data. Some of the most affected countries like India are notorious for just rampant underreporting of mortality data. We had to look at fertility rates. We had to extrapolate from 21 countries. Really, they accounted for about 75% of the mortality. So I think they were a good set, but there was work done there. I was not involved in the specific numbers. I worked more on the policy recommendation side of the study. But it was a really impressive team from the CDC, WHO, and universities that worked hard on this and eventually got it accepted by the Lancet. When it came to the United States and the data for here, we had a bit of an easier time because of just the availability from the various databases, the CDC National Center for Health Statistics and others, which made it a bit easier to look at what's been happening and to break it down by state, race, and ethnicity. We'll be seeing some very interesting findings on that shortly. We had three classifications that we looked at, each of which mattered. The first was children who lost one or both parents, which is defined by UNICEF as orphanhood. Most children that we'll be talking about today lost only one parent. From what we could tell, very, very few, just a negligible number, lost two parents to the disease globally. But a lot of children live in homes that are not, they live outside of homes with their parents. They live with grandparents. They're providing primary care. We'll be discussing that briefly. And so we thought it important to include the loss of primary caregivers where children already weren't living with parents. A good example of this is in sub-Saharan Africa with HIV. A lot of children lost parents to HIV and ended up living with grandparents. When COVID-19 hit, it was killing that older population and leaving some of those children bereft of care that was being provided by those grandparents. That's just one example. And then we wanted to look at co-residing caregivers, particularly grandparents living in the home. Studies show globally that they really provide in many cases, a very important role in supporting the household, caregiving for the children that allows parents to work, that improves household income. Many of them have savings. They provide other kinds of support for education and schooling. There are studies published on this. So there are effects that we just wanted to capture here, though the primary ones are the first two categories. And if you've known Dana, even for a fraction of the time you've known me, you know that this issue of families is at the core of the research that we're presenting. Children are wired to be in families, and if those families are safe and nurturing, as in Dana's example of his own life, we see that children have their best potential from a cognitive, physical, linguistic, social, and emotional standpoint to develop. And this often isn't recognized in the world that's been very focused on and I think quite appropriately focused on primary healthcare, literacy, primary education, infrastructure, poverty reduction. We haven't always seen in the global dialogue the focus on the actual environments that children are living in. and what a bearing that has on the welfare of communities and families. And so this is an emerging area that's just starting to develop in the last few years. Loss of parent is an adverse childhood experience, at least in the opinion of the organizations at the base of this slide. Adverse childhood experiences, there are only a few in the formal set, but there's actually a pretty bewildering number when we look at it. And they're really specific to each child, and what happens when a child loses a parent can really play out in so many different ways. It can be an impact on poverty and loss of income. It could lead to psychosocial issues and mental health issues, bereavement related, increases in substance abuse and the like. Any child may have any different combination of these bubbles, but there's no question from the research about the severity of the loss of a parent and how that can tie in to other kinds of concerns that we may have about children's well-being. And grandparents, it's just alluded to this a bit, and some of why we thought this was so important in the research, but it's not a small number of children who live with grandparents. Globally, it's about 38% of children, and in the Asia Pacific, it's about 50%. So we thought this again to be a significant area that we just had to capture. Even in a country like Brazil, such a striking number. They were hit so hard by COVID-19. 70% of children received some care from grandparents. So that was a real hit on children in that country. Now, this was really the inspiration for our research. Some of us have been around the block a bit, working in international development for decades. And we remembered what happened with HIV, which was discovered in 1981. It took years for the global community to wake up to the fact that all those deaths from HIV were leaving children behind without care. And there was some response. In fact, the United States has put billions of dollars into HIV mitigation through the PEPFAR program over some decades now. So it's been a really amazing program with respect to providing antiretrovirals and addressing HIV. But when we look at that discovery of HIV in 1981, and almost a decade later, there were 903,000 children who lost a parent to the disease, which we considered to be a crisis at the time. In the very beginning of the pandemic, in 1 year, we had already exceeded that number. It took a decade for HIV to get to there. So that was an alarm bell for us right there and then. And we can move on and just break it out a little bit. The numbers were doubling every few months. As the mortality increased globally, the number of children who were losing care, in fact, exceeded the number of deaths, because many families have more than one child, several children. So we saw more children affected than we saw actual mortality from the disease itself, and a pretty steep curve until the end of last year, where we end up around 12.5 million children so affected. And you're probably wondering how that broke out by the classifications. About 3/4 of them lost a parent, so a pretty significant set. And that ups a bit when we look at the loss of a primary caregiver. That's inclusive of loss of a parent. And then maybe 3.3 million who lost a grandparent that was co-residing in the household with them. This also was the alarm bell for us. You can see, largely as a result of HIV, but some other factors too, children who were newly losing parents year by year from 1990 steadily increased, particularly as HIV progressed, until around 2004, 2005. And then all those programs finally started to kick in and reduce mortality from HIV. And we saw that nice reduction. And we were really feeling good about that. Global poverty was going down, HIV was going down, the number of children affected was going down. COVID hits, and then almost overnight, look at those purple bars on the right, the number of children losing a parent just skyrockets again and dwarfs anything that we saw in such a short period of time from HIV/AIDS. And let me see if I can do this. This just plays out the progression of the loss of parent and caregiver globally from the start of the pandemic. There we go. Affecting, yes, high-income countries like our own, but also significant portions of sub-Saharan Africa, Latin America, Asia, and Europe and Russia. So it won't be surprising to you that most of the children losing a parent or caregiver are adolescents. This is because when you look at the mortality curve from the disease by age, it is affecting mostly older adults, and the level of mortality goes down as you look at younger ages. So it predominantly will be adolescents that you'll see who are losing care. We look at risks for children quite differently, whether they're infants or those earliest ages, 2, 3, 4 years of age, versus adolescents who have a specific set of risks. So we just tried to highlight here some of the specific primary risks that are coming from all of this mortality and loss, and that the fact that adolescents are predominantly affected. And there was much more male mortality, as you know, than female mortality. So that translated into a greater loss of fathers around the world. I think you can see the US, a little arrow there on the right, and where we fit on that. But again, the loss of a father leads typically, not universally, but typically to a specific set of risks for children, primarily lost income, because they tend to be primary breadwinners in a lot of households, but other risks as well that have been highlighted. Now let's turn to the United States of America. This was a number that did get a lot of press when we released it, because it's big. Over 222,000 children who lost a parent to COVID-19 across this country. And you can see the curve there. It's obviously flattened out quite substantially as the pandemic has eased with respect to mortality. And then it ups a bit to about 238,000 when we look at other primary caregivers, and about 280,000 when we look at including co-residing great-grandparents. This widget is available. I think you can Google it on Imperial College COVID-19 orphanhood widget. That's all you need to put in, or I can get it to you afterwards if you like. And a few of the characteristics of children's living arrangements in the United States, 23% live in single-parent households. So if one of those parents are hit, that leaves the children a double orphan, if you will, losing both. 10% of children in the country live with a grandparent, and those grandparents provide significant support to those children. So loss of grandparent was not inconsequential here in the States. And the racial and ethnic disparities, pretty shocking here. The white population, 1 in 753 children lost a parent or caregiver in the States, but you see Latino, Black, and Native American substantially higher in percentage terms losses of parent and caregivers. So there's a real inequity here that was highlighted in the data. Pediatrics, if you try to generate a complex slide, it turns out unreadable. I'm sorry about that, but I'm going to put a little bit of an arrow here just to show where Minnesota comes out in all of this in terms of loss of primary caregiver. The mortality in Minnesota was below the mean, as you can see on the right. So we were a bit better off than the rest of the country. And if you look at that in terms of primary caregiver, not surprisingly, you'll see the same thing occurring here. But you'll also see in our great state the same kind of disparities that you were seeing across the United States. The non-Hispanic white population in Minnesota is almost 80% of the total state population, but only accounted for about 48% of the loss of primary caregiver. You can see for other populations, they suffered much more disproportionately, and really highlighting the non-Hispanic American Indian Alaska Native figure, where such a small percentage of the population, because of how hard they were hit by COVID, experienced substantial loss in our state. The total number of children is about 1,358, according to the data, with a range there. So it isn't the biggest issue. You may not have seen it in your practices here because of our large child population, and we were a bit better off, but still, every child matters. One other thing I just wanted to highlight about COVID-19 and how it's so different from HIV and what we saw in those earlier charts comparing them is that it kills quickly. It's a lot like Ebola in that respect. families don't have any time to prepare. It's days or weeks. And I personally have known people who've lost adults around the globe to COVID-19, and it was just overnight and occurring in such large numbers. So that really has had some pretty significant implications about how we think about the disease and respond to it. And with respect to response, and I'll be closing up here, our team came up with the 3 Ps: prevention, preparation, and protection for the general approaches that we need to take to handle what we call the hidden pandemic. Prevention was really equitable access to vaccines and other measures to prevent the spread of COVID-19 and its mortality rates. Parts of the globe have had much more difficulty accessing vaccinations and other therapies for COVID-19. If we prevent the mortality, we prevent the loss of parent. It's that simple. So we have been promoting that quite heavily in conversations with White House, with US Congress, with global actors, and the like. We don't want to forget the health dimension of this. Prepare. We want to avoid that these children end up in residential care like orphanages, children homes, and the like, which is a substantial risk. When you look around the globe, we don't have developed child welfare and protection systems, foster care, adoption, guardianship that are regulated in any way. We have a fair amount of kinship care where children end up in other people's homes, usually relatives. But child protection and child welfare systems are just not terribly developed. What we do have is really established network of orphanages and children homes. US donors alone are contributing billions of dollars to these annually. There's a recent study of this, I think 2-3 years ago, by the Barna Group, just to the extent of that. So sometimes the default measure that's available when a child loses a parent or carer is to put them into one of these settings, which the research shows is so harmful for them. So we really want to prepare communities to avoid that outcome and support children and families. It's not only better for them to be in families, you can serve 6 to 10 children in a family for the cost of 1 child in residential care. It's so expensive to put them in an orphanage. Dana, you're familiar with this slide, I think. The Lancet Commission on the Institutionalization and Deinstitutionalization of Children did a meta-analysis of a very large set of studies showing the impact of institutional care on a number of measures: growth, health, head circumference, cognition, and the like. And the right-hand photo is from the Bucharest Early Intervention Project that Dana worked on, showing brain activity, brain power for children in institutional care vis-a-vis never institutionalized. Really dramatic difference. And notably, when children are taken out of institutions and placed in families, we really see a lot of recovery on these and other measures. So this is what we're trying to develop globally. There's really an amazing recognition by most state agencies that these are the way to go: family-based care options for children affected by COVID-19, but for other reasons too, whatever the cause of the loss of parent may be, and transitioning away from that residential care option that we were just talking about. And finally, parenting programs really have just taken off, and we're finding amazing results. We've had quite a few randomized control trials that have just been undertaken that are just showing amazing results in terms of preventing issues, reducing violence against children in the household and the like. There's a big emphasis on making this part of a package or a tool globally. Many of these programs can be delivered remotely, so that's pretty neat. In Tanzania, just one of the many studies showing pretty significant reductions in violence against children, intimate partner violence, violence in schools, and the like. So we're really honing in on this area of parenting programs. And then finally, protection, trying to look at these broader issues of child adversity. All those bubbles earlier, the bewildering set of bubbles that I showed. There are a set of programs that are specialized that we really need to look at to prevent and respond to children's needs globally. And the role of social work. The only way to deal with that bewildering set of bubbles is really to look at each child's unique circumstance. You could be in a village in Malawi And one home could have an issue with a child with disability, and the home next door could be having loss of a parent and increased poverty, maybe 12 children in the home. Every home is unique, and the only way we're going to get at that is by having a mechanism to properly assess the needs of each child and family, to come up with a plan, and to refer those children to services that are available. Those could be provided by sometimes the government, though governments locally are a little weak around the world, to say the least, but sometimes by community-based organizations, faith-based groups, other informal mechanisms that are available. So there's a big push now on getting social work on the agenda to complement the health sector and the education sectors with that crucial pillar of social policy. So just to say, let's say you have someone come into your clinic or your practice, and they are affected by the loss of a parent or caregiver. Where do you turn? The AMC. Best in class, right? Been around for decades. They literally much more than I do. That beautiful photo of all the staff there and their expertise. They'll know where to go. They'll know what questions to ask. They'll know what kind of diagnostic protocols to utilize. They'll know where the experts are here. And as we've noted, this is just not a global issue. It's a U.S. issue. It's a Minnesota issue. And you'll probably see those touched by it. And let's hope that the pandemic stays where it is now and even declines further at the moment. I want to thank you for your attention, and once again, an honor to be here for you, Dana, and wish you all the best. Thank you. If there are any questions.
I'll start.
Sure.
So in looking at the last grouping of slides, one of the things you talked about was prevention and part of immunization. In your work across the world, do you suffer from the same misinformation problem that we suffer from in the US, where we actually have the resource but can't deliver it?
Sadly, yes. Vaccine hesitancy is not just a US phenomena, it's very much a global phenomenon. So even in some of those poorest countries in that slide that we were showing, where the need was so great for vaccine and where they were having some access problems, there was a great deal of difficulty in not just physically distributing the vaccinations to needy populations, but also getting them to trust in the vaccination itself. A lot of misinformation filtered from here and other countries into the rest of the world as well. So we still see immunization rates well short of where we'd like to see them around the world. And it's in part a logistical issue, but in part it's also the hesitancy issue. Do we have a, yeah.
Thank you so much. That was sort of scary, honestly, to think about the well-being of our kids in Minnesota around the world. I'm Emily Borman-Chope. I'm a general pediatrician here in the department, and I would be curious to hear your thoughts on partnership with schools and if you use educational data in any of your analyses, especially thinking about all those vulnerable teenagers that you mentioned.
Yeah, and how profound a question that became with quarantine, when there was that lack of access to schools, which get children out of the house. Schools can be safe and protected spaces for kids. So 1 billion children being removed from them had the consequences that I mentioned. Yeah, we see this as a cross-sectoral set of issues. So it is the education sector, it's the health sector, and that's building up that social welfare piece that is lacking and working across all three. So I specifically, what can you say about education? The World Bank just 2 or 3 weeks ago came out with a pretty concerning report on lost earnings due to lack of education over the years of quarantine, indicating that trillions of dollars in today's terms of future earnings have been lost due to inability of students to become more literate, to go through primary, secondary school and the like. It's a whole calculation. We know that education is the greatest driver of poverty reduction. The more children are educated, the more we see that reduction in poverty. Lots of data demonstrates that. So a big reversal, when we lost those education years, we have these projected impacts. Like the UNICEF report where they said worst time for children that they've ever seen, the World Bank in a way was echoing that, but looking at it more through the prism of education.
Thank you. That made me think of a follow-up question. The loss of wages for parents, especially for a primary wage earner. Do you think people will look at that down the road, the teenagers who don't go to community college or trade training or college 3-4 years from now because their family doesn't have enough money anymore due to loss of a caregiver?
Yes, I think we're going to be studying this for years, and it's going to be playing out on so many dimensions. And we should have picked a more uplifting topic, Dana, I suppose, than the one we ended up on. But we agreed it was important for the information to be out there. It is going to be earnings losses. It's going to be more, we think, social problems in the communities, more children and teens in contact with the law, more social work demand across the board. And so there'll be a need. If you're looking for a research topic, I'm sure we could find one for you. Yes.
One more question.
One more.
Thank you for an excellent talk. I thought the perfect storm analogy was really relevant, and wondering that as the storm subsides, the conditions are still there globally for some of these issues. How much has the effort been impaired by the persistence? Like, as you're trying to respond, are you finding things are opening yet, or you're still struggling in that global impact?
We're still struggling. Just as the pandemic was easing, Russia invaded Ukraine just over a year ago. Now that obviously led to a major refugee issue, millions and millions of displaced children within Ukraine and outside, about 7.5 million children in the country as a whole affected by it. That on top of the Syrian refugee crisis and Northern African refugee crisis, Afghanistan. But then Ukraine plays a critical role in food markets. And so we started to see spillover effects largely in sub-Saharan Africa, which depends on the grain markets from that part of the world. I was there last June and the inflation was just substantial, the increase in food insecurity, and it went on. So it just felt like we were about to take a breath. As you were suggesting, maybe we'll have a chance to absorb what COVID did and then move on. Sadly, it still feels like it's quite challenging out there. But there is, you saw the range of organizations there. They're really collaborating and working together. We have a reference group ongoing, WHO, USAID, World Bank, many others, meeting regularly to discuss the response, to make sure that agencies are aware of it and to mobilize resources.
So this is going to wrap up for today, our first in-person grand rounds we've had. So thank you, everyone, and thank you, Mr. Goldman, for an elucidating, if not kind of wake-up talk. So, and once again, Dana, congratulations on behalf of everyone here. So thank you.